earlier two speakers are not there, I will kindly request Dr. Rajwinder Kaur Battal to bring her presentation first. I know it's a big letdown after all that movie type atmosphere. Suddenly we are back to a dull retina.
Should I start? Good afternoon, everyone. So my topic is intravitreal anti-VEGF injections, what, when, and how. So I want to thank my mentor, Dr. Khan, for giving me the training, what I am doing in the retina because of him. So the introduction of drugs through the pars plana directly into the vitreous. It is the gold standard for many retinal diseases. So it is a highly targeted treatment, and by giving intravitreal injection, maximum therapeutic concentrations with minimum side effects are there. So when we talk about the history, in 1911, the Dukemans and Ohm injected air bubble to tamponade the retinal detachment. And in 1944, the intravitreal penicillin was injected in endophthalmitis cases. And in 1970 to 74, the successful treatment for the endophthalmitis by this route. And in 1988, that is Vitravine for the CMV retinitis was approved by FDA. So there are various anti-VEGF injections. So the indications we all know, wet AMD, macular edema, diabetic and retinal vein occlusions, BRVO, CRVO, choroidal neovascularization, PCV, ROP, and neovascular glaucoma. So when we talk about that is anti-VEGF injections, they are ranibizumab, bevacizumab, pegaptenib, aflibercept, brolucizumab, faricimab, and biosimilars. So in steroids, we have triamcinolone, dexamethasone, and fluocinolone, and ozurdex implant. So by pictures, we can, VEGF is the vasculoendothelial growth factor. Anti-VEGF agents block the VEGF molecules and thus benefit the patients by decreasing the abnormal and the harmful new blood vessels formation and by decreasing the leakage and the swelling of the retina. So what is the VEGF family? So the anti-VEGF mainly targets the VEGF-A level, and the VEGF-B, C, and D, they are also known for the vasculogenesis, and PIGF important for the vasculogenesis. So the most of the anti-VEGF, they target the VEGF-A. So in the angiogenesis, there is a migration of the endothelial cells, increased mitosis of the endothelial cells, increased matrix metalloproteinase activities, and chemotactic for the macrophages and granulocytes. So vasodilatation indirectly by the NO release. So the common indications, they are at the AMD, venous inclusions, diabetic macular edema, CNVM, neovascular glaucoma, and the preoperatively we can give in PDR surgeries and the vitreous hemorrhage cases. So the indications, previously the vein vasculitis was known as Eales disease, refractory post-surgery CME, Coats disease, ROP, ocular tumors, we can try that, macular edema due to the, that is radiation retinopathy, then iris neovascularization, and pterygium, there are many studies they have used in the pterygium also, trabeculectomy for the wound healing modulation. So the contraindication. So whenever there is a fibrovascular proliferation which is threatening the macula, it is absolute contraindication. So the active and the periocular inflammation, and then it is contraindication if the patient has a recent stroke within 3 months, then it is contraindication. And patient hypersensitivity to ranibizumab or bevacizumab, which is very less known. So first of all, in pegaptenib in 2004, it was launched, and in 2006, the ranibizumab was launched. Then after that, aflibercept, and then after that, brolucizumab, faricimab, and bevacizumab is still used in that is underdeveloped countries because of its low cost. So the newer anti-VEGF, brolucizumab 6 milligram and faricimab 6 milligram. So it is so this is, we can see this table, that the bevacizumab and ranibizumab, these are the recombinant humanized monoclonal antibodies. and aflibercept, that is recombinant fusion protein, and pagapatinib is a pegylated aptamer. So brolucizumab is a recombinant human monoclonal antibody. So in the size, we can see that the brolucizumab is of the molecular weight is 26 kilodalton. So it has the highest affinity for VEGF-A levels, whereas the Eylea has affinity for the VEGF-A, B, and PEGF. So the adverse effects can be the ocular endophthalmitis, there can be the ocular hemorrhage in the form of subconjunctival hemorrhage, there can be the raised IOP, cataract, if you have hit the lens, that is the Rosa's type of cataract you can see after that. Then the retinal tears, if you have gone before the 4 mm, and then intraocular inflammation, it is more commonly noticed with brolucizumab, and rarely you can have the very less known complications such as the retinal toxicity. And the systemic contraindications, MIS I have already told, and deep vein thrombosis, pulmonary embolism, and thrombophlebitis. So in the injections, we have 3 injections, and the indications I have already told. So the Ozurdex, it is the FDA approved, that is extended release intravitreal dexamethasone implant, and it lasts for 3 to 6 months. So the adverse effect, that is cataract formation, and then is IOP rise, and very rarely it can cause the endophthalmitis. So pre-injections, that is always confirm the name of the patient and the eye of the patient, and confirm again the indication and the type of the intravitreal injection. When you are using the bevacizumab, because it is off-label use, so it is very important to explain the patient all the other options also. So the equipment is sterile, raped, then it povidone in the eye for the 5%, and that is on the lids 10%, and then it is usually given on topical anesthesia, and that is 2 to 3 minutes after the povidone iodine painting we should wait for, and a sterile speculum should be used, and the topic under all sterile conditions we can inject the that is intravitreal injections. So to minimize the risk of endophthalmitis, that is povidone iodine usage, and when we are injecting, we should not talk. So the face mask is very important. So the gloves and the pre-filled syringes, and you can use that is the 30 gauge needle, and the distance has to be maintained. If the patient is pseudophakic, 3.5 mm, if the patient is phakic, then the 4 mm. So according to the age, the distance of the injection from the limbus, it is very important, and less than 6 months, that is 1 to 1.5 mm, and then less than 1 year 2 mm, then 2 years 2.5, and then that is in the normal age group according to the status of the lens. So with the help of 26 gauge needle, you can inject the injection. 0.05 ml. This is a small video showing how to give the injection, most commonly in the inferior temporal quadrant. Always ask the patient to see opposite to the quadrant. Then override the conjunctiva over the lesion with the help of the swab. And if you are not sure, always use the caliper to be sure of the distance. And that in cases of DEXA implant.
Ma'am, time is up. Can you conclude?
Okay, just this video only, sir. So in this case, you have to go through making a tunnel, so that because it is a big gauge needle, so you have to take care of you have to make a tunnel, and then enter into the vitreous cavity. And most commonly, it can be given in the inferior nasal quadrant. So in the ROP babies, in the subsequent lectures, they are discussing the retinopathy of prematurity, and brolucizumab will be discussed in detail. So I will be leaving that. Thank you so much.
Very comprehensive presentation on anti-VEGFs, and compressed into a few minutes. It's not easy. So any questions, any comments, judges, co-chairman, audience?
Tricot injection, any special precautions when you give intravitreal triamcinolone acetonide?
Before giving any, that is steroids, we should look for the intraocular pressure before giving the injection, and also the status of the disc is very important.
So how do you?
And if the patient is a phakic also, we can avoid that also, the DEXA, and because there are high chances for the cataract formation and the glaucoma in that cases.
So this can form precipitates inside the in the vitreous cavity. So better to give it in the lower quadrants rather than the upper quadrant, so that it doesn't come into the vision.
Yes, sir. Yes, ma'am.
Thank you.
The next talk will be by Dr. Saurabh. The talk will be beyond inhibition, exploring the unique molecular properties of anti-VEGF.
Good afternoon. I'll be talking about beyond inhibition, exploring the unique molecular properties of anti-VEGF agents. So this is a disclaimer. So several molecular factors determine how a drug interacts with the body: the binding affinity, the elimination half-life, the potency, the clinical targets, and the molar dose. So individual studies assessing the molecular properties of intravitreal anti-VEGF agents have suggested that there are key differences between agents in terms of VEGF binding affinity, relative potency, and intraocular half-life. So binding affinity determines how strongly a drug interacts with its target. So we can see here a comparison between the different anti-VEGF agents, and this is data from head-to-head studies in the binding affinity with VEGF, where we can see that aflibercept was found to have statistically higher VEGF binding affinity than brolucizumab and ranibizumab in a head-to-head study. Potency determines the required concentration of a drug to produce a defined effect. So again, this is a data from head-to-head study of the potency of these various drugs, where you can see that aflibercept is significantly more potent than brolucizumab and ranibizumab in vitro. A lower IC value means increased potency here. So you can see here a potency of 2.42 for aflibercept. Half-life provides an insight into the drug concentration in the body over time. And data from independent studies where you can see that the estimated human half-life of aflibercept is about 9.1 to 11 days, which is more than that of ranibizumab and faricimab, and also of brolucizumab. Binding target determines downstream effects of a drug on disease pathology, and we can see here that aflibercept binds not only VEGF-A but also PIGF, VEGF-B, and galectin-1, as opposed to the other agents which bind predominantly VEGF-A, and in case of faricimab, Ang2 as well. So currently available and approved anti-VEGF agents, this is again a comparison of the binding affinity, estimated human half-life, equivalent molar dose, number of targets, and potency, where you can see that the aflibercept has multi targets which are being targeted, and the potency is 2.42. So the VEGF receptor signaling pathway is the master regulator of pathological angiogenesis. However, in pathological conditions beside VEGF, PIGF levels also are increased due to hypoxia. This is a cartoon depicting how that happens. Aflibercept significantly decreased intraocular VEGF and PLGF levels from baseline to month 2 in patients with DME. And VEGF and PLGF are upregulated in exudative retinal diseases such as diabetic retinopathy, diabetic macular edema, and neovascular AMD. Here you can see that in patients with DME, VEGF levels are up to 61 times higher, PLGF levels are up to 19 times higher. In patients with RVO, they are 154 times higher and 14.5 times higher respectively. In high VEGF states, Ang2 blocks the Tie2 receptor, increasing vascular permeability and neovascularization. So how relevant is targeting Ang2 to managing retinal disease? VEGF is a pivotal mediator of pathology in retinal disease, increasing the vascular permeability and the formation of pathological vessels and macular edema. Inhibition of VEGF can reduce the incidence of these events. Ang2 level can be suppressed with any other anti-VEGF, aflibercept, ranibizumab, and bevacizumab. So we know that the results of this study support the hypothesis that Ang2 may be expressed secondary to primary insults to retinal vasculature by VEGF, and direct inhibition of Ang2 may not be clinically relevant as this is currently provided by anti-VEGF treatment alone. Baer and Regeneron have investigated the Ang2 pathway in combination with aflibercept in the Ruby and the Onyx studies. This is data from independent studies shown here, where faricimab has a weaker binding affinity for Ang2 than for the Tie2 receptors, and nesvacumab has a stronger binding affinity for Ang2 than for the Tie2 receptors. So no additional clinical benefits have been found with potent Ang2 inhibition in combination with aflibercept in these two studies, that is the Ruby and the Onyx. And it was discontinued primarily because combination therapy was non-inferior to aflibercept monotherapy for change in BCVA at week 12 and week 36 endpoints. There was no efficacy improvement noted in neovascular AMD or DME. Therefore, aflibercept Ang2 program was discontinued. No vision benefit with faricimab versus ranibizumab in neovascular AMD in the Avenue study for neovascular AMD. No statistically significant difference in BCVA and in secondary functional or anatomic outcomes between faricimab and ranibizumab were observed. So in Avenue, ranibizumab and faricimab achieved similar levels of plasma Ang2 inhibition after one injection. In Avenue, again, you can see here that data suggests that anti-VEGF monotherapy neutralizes Ang2 to levels comparable to that of directly targeting Ang2, supporting the known biological activity of Ang2, whereby its activity is downregulated by decreasing VEGF-A levels. In an FDA review comments on relevance of Ang2 in retinal disorder, it says that the contribution of Ang2 inhibition to the treatment effect and clinical response for neovascular AMD and DME has yet to be established. No vision benefit was again seen with faricimab versus aflibercept in neovascular AMD in various studies like Yosemite, Rhine, Tenaya, and Lucerne. The activity of faricimab may be derived primarily from its ranibizumab arm. So this is, there was no proven clinical benefit with Ang2 inhibition. Could be that the higher molar dose of ranibizumab FAB arm may be responsible for the faricimab treatment effect. There is a disparity in vision gains among faricimab treated patients, as was evident when the treatment arms were separated in year 1. The FDA analysis of year 1 data revealed that in Lucerne patients receiving a Q12 faricimab lost vision over time, and in the Tenaya patients receiving Q8 and Q12 faricimab also lost vision over time, suggesting that they may be having an undertreated, they may have been undertreated. A similar analysis of the year 2 results may provide insights into differences in treatment response between the faricimab 6 mg dose groups. So does faricimab offer durability advantages versus aflibercept? There is no direct comparison of durability in neovascular AMD because of the phase 3 study design. Select baseline characteristics in Tenaya and Lucerne suggest patients were good candidates for extension in neovascular AMD. So the contribution of Ang2 inhibition to the treatment effect and clinical response for neovascular and DME has yet to be established. So with aflibercept 2 mg already targeting key ligands of the master regulator VEGF pathway, there may be limited potential for improvement in functional outcomes for patients. Increasing the molar dose of anti-VEGF agent may have the potential to offer patients more through extended VEGF suppression. Have we maximized outcomes for our patients, or can we go further with disease control? Aflibercept 2 mg has set the bar high for treatment of exudative retinal disease, with novel agents yet to surpass its standard of care vision gains, durability and safety profile across indications. Aflibercept targets the key ligands of the VEGF pathway, the master regulator of pathological angiogenesis. Targeting other pathways has not resulted in improved patient outcomes beyond aflibercept. Data from Pulsar and Photon suggest that aflibercept 8 mg, which is due to become available in India shortly, has potential for greater and longer lasting control of the underlying disease compared with aflibercept 2 mg through sustained disease control. Thank you. At this point, I would just like to share, some case which I have. I think it's here only, sorry. So this was a case, first came to us in 2016, known case of diabetes type 2 since 94. Initial diagnosis which we made was high-risk PDR in the right eye with CSME and pre-retinal hemorrhage and OS moderate NPDR. and underwent a lot of laser, and you can see the number of injections there, about 6 Lucentis, 1 Eylea, 5 Ozurdex in the right eye, and 4 Lucentis and 1 Ozurdex in the left eye. This was how the systemic parameters looked, so they were fairly well controlled. And this is the initial clinical picture with a vision of 612 parts in the right eye and 66 parts in the left. And underwent these injections and laser. You can see a fair amount of macular edema in the right eye. And left eye underwent 2 sittings of sparse PRP initially, and then had these injections over the successive years, 2016, 2017. Even Ozurdex was given in the right eye, but the edema would come back with as very regularly. Patient underwent cataract surgery. I'll be just finishing in 1 minute. And finally, the patient was switched over to Eylea in the right eye in 2019. And this is what the patient looked like about 4 years down the line, and with a fluctuating course of macular edema. And between 2020 and 24, in the last 4 years, again patient received predominantly Eylea injections, and has good resolution of DME with injection Eylea as compared to Ozurdex. And this is the final follow-up that we have very recently, where the patient is doing fairly well with very less requirement for anti-VEGF treatment, mostly stabilized. And the left eye has shown a few spikes of edema, but again with Eylea it's controlled well. Thank you.
I think, sir, a very interesting talk. As far as these, if you go purely by molecular characteristics, sir, I find it rather confusing at times, because our interest is potency and duration, majorly. So many times I find the various molecular characteristics not commensurate with what I expect. But your summarizing these things will probably give us a better idea in general.
So like, as there is a gap between Lucentis more than 1 month, is the similar gap, can we increase with Eylea also more than 1 month?
More than 1 month, I couldn't get the question.
What I mean is, in between 2 Eylea injections, how much gap we keep for DME or NAMD? Is it different?
So normally we know that Eylea, it lasts for about 6 weeks, as opposed to the monthly, regimen which we used to follow for ranibizumab, because it is definitely a stronger agent than ranibizumab. So, we definitely watch for 6 weeks, and only after that, we need to, consider repeating an Eylea injection.
So it was the same for DME and AMD both?
No. So, in DME, initially, I think what has been advised is that we use up to 6 loading doses, which again in the Indian context becomes very difficult. It is very almost, impossible to convince the patient to go for 6 injections in the beginning. So we end up, mostly initially on a loading dose, but not 6 for sure, maybe 2 to 3 injections. And then after that, we watch, for the edema to come back, and then we can retreat. Yes.
Very nice presentation, Dr. Saurabh. I think it's beyond doubt now that with both the drugs being in the market for long, I think both are equally safer. And so I think that part is out of question now. I think what needs to be seen now is that obviously, this data does have a little bit of this thing, because we could say that it was a little biased because of 2 weekly and 6 weekly, but then that was a protocol which had to be followed in some way. I think it would be interesting to see, as you had shown the last slide, with 8 mg coming in, then we'll really know where we stand and which would be the most beneficial for the patients. But as of now, I think both seem to be quite wonderful, doing very well. Until
now, I think in the Western world, no safety data has come out, of concern for Eylea, HD. So I think, that is a promising treatment approach that we might have soon.
Yeah, maybe they can plan a more balanced trial.
Right.
Yeah.
Sir, regarding the increasing dose, sometimes we use Zaltrap, that is kind of a Avastin kind of thing. So sometimes we are not able to titrate the exact dose. So some patient might get an extra dose, and I see those patients who have got an extra dose, they developed inflammation.
They did?
Inflammation.
They did develop inflammation, okay. With Zaltrap.
Very mild inflammation which goes away within a week or
With
5 days.
Zaltrap? With Zaltrap?
No, not with Zaltrap, with higher dose.
Okay, but again, when you've not titrated the dose, it's really difficult to say. But once we have an 8 mg volume of that drug, then I think we'll be in a better position to comment whether we see anything of the sort that we see with the higher molar dose with the other 2 injections that we have been seeing. Not very common, but I've seen in my practice with the heavier molecules. I mean the higher molality molecules.
Okay.
Thank you.
Thank you, sir.
Thank you.
We are not aware who's the next speaker, if he has come. Dr. Pratik Mahajan.
So good afternoon, everyone. So I'll be speaking about the drug bevacizumab. As we all know that we are using anti-VEGF for mainly these 5 indications: IPCV, AMD, DME, CRVO, CSR. So now the question is, brolucizumab, you ask me that whether I am using as a first line bevacizumab in these diseases. Yes. IPCV, I am using as a first line now. AMD, yes. DME, maybe not. CRVO, yes. CSR, no. So as a first line therapy, I am using in IPCV, AMD, and CRVO cases. Because the initial experience was somewhat, we were getting some intraocular inflammations, retinal vascular occlusions. But in this year or the last year, they have somewhat modified the molecule, and the rate of intraocular inflammation or vascular occlusion is very, very less. So the brolucizumab, everybody knows about the drying effect. It has a very faster, very longer, and very sustained drying effect. That's why this molecule is used nowadays very, very commonly. And that's why the company has increased the price to 28,000 per while now. So we have analyzed the data of around 100 eyes, and the main outcome measures were BCVA, intraretinal fluid, subretinal fluid, central subfoveal thickness, and pigment epithelial detachment. And these were the number of, most of the patients were having AMD and CRVO. So directly coming to the, first the bad things or the good things, the bad things. The bad things we had in the initial 100 cases was 2 patients, I had RP RIP, 2 patients had hypopion, and out of which 1 needed vitrectomy. And in 2 diabetic cases, there was an increase in tractional retinal detachment, and these patients were managed with vitrectomy. So the case 1, you can see the drying effect of brolucizumab. It decreases the height of PED, it decreases the IRF, it decreases the SRF, and most importantly, it is the IRF, intraretinal fluid, which is most dangerous for the eyes. And you will ask me whether you can tolerate any fluid. No. No IRF, no SRF. You cannot tolerate any fluid. The retina should be dry. Even if it is IMD case, IPCV case, diabetic, maybe yes. But other cases, everybody wants a dry retina. So brolucizumab, faster effect, within 7 days you can see the height of the PD decreasing, the SRF decreasing. It has a longer, remains for 3 months, and it is a sustained effect. So brolucizumab. And with the very 1 to our patients, most of them, more than 80% have 1 to 2 line improvement of vision at the end of 1 year. So case 2 again, 82-year male, wet AMD, 6/60 vision. You can see at the end of even 1 month of follow-up, not even 3 months, you can see the intraretinal fluid has decreased, the PED has gone down, and so this is I had the recent, would you ask me again, whether in a 6/6 case you can give Pagenex? Yes, I have given. He was my friend. 6/6, he's a laparoscopic surgeon. 6/6 vision with multiple PEDs in both the eyes. So 6 months back, I injected on his insistence. I was very reluctant. What will happen if something happens? He says, doctor, I have a full belief in you, go ahead. So 6/6 vision, multiple PEDs, a laparoscopic surgeon. So I injected, and believe me, within 7 days, the PEDs were flat. And till date, we repeated in the other eye, and till date, 6 months follow-up, he has not again needed a second repeat injection. So it is the beauty. So you can see the PED going down, the subretinal fluid going down. So diabetic macular edema, these cases, they do need repeated injections. So you have to follow them up for hypertension, a good glycemic control, a good lipid level control. And I don't follow a monthly regime, 3 monthly, loading doses, and then PRN as PRN basis. So central retinal vein occlusion, non-ischemic CRVOs, they do very well. 1 or 2 injections are sufficient. Ischemics, they need a longer treatment. So central serious acute cases, I do not give bevacizumab as a first-line therapy. Only if the 2 months have passed, you have exhausted all your options, eplerenone, other drugs, spironolactone, and you've done every other profile. The CSR, the experience was more than 50% cases, they responded. But more than 50%, maybe those who are having a pachychoroid, they are better responders to bevacizumab, and this was more than 50% cases, they did not respond to bevacizumab. So this is the patient. He's a 85-year-old physician. My friend's father, he got RP RIP. So this was the initial period when I used to give Pagenex with injection 0.0 ml DEXA also. So I used to give DEXA also. So in this case, it is an old case, I give DEXA. First injection didn't happen anything. Second injection, he got RP RIP. The vision dropped from 6/12 to counting finger. And then he was lost to follow up, although he's a friend of mine till now, but his father never comes back to me. So these are the things you should keep in mind by giving brolucizumab. Excellent drug. Thank you very much.
You have shown one case of CSR.
Yes, ma'am. Yeah.
Is it clear-cut indication for anti-VEGF because there is no
No.
Opta
Acute
image is
cases
not
for
there?
initial 2 months, we don't give brolucizumab. We follow, stop the steroid if the patient is taking, get his profile done. Acute CSR, no. Only if 2 months have passed, the fluid is not going down, the vision is severely impaired, only then we have tried. But like out of 20 cases now, 10 have responded, 10 have not benefited from the drug. We try brolucizumab, yes. After 2 months, if the fluid has not come even down a little bit, the vision is, we are not having, we are buying. At present, we are not having Octa.
There is no doubt in my mind the drying effect of Pagenex is fantastic. I'll give a short summary in one line. Earlier, 1.5 years back, I was in the government and I used Pagenex for primary indication everywhere. For last 1.5 years, I'm in the private. For treatment naive cases, I am slightly hesitant in using.
Sir, now whatever they, like in the this year, we have not encountered even a single inflammation, sir, or single vein occlusions. So we have tried primarily as in even treatment naive patients, AMD patients, CRVO patients who are having glaucoma and in which you cannot give steroids and you want a sustained effect. So beautiful, beautiful, very good results.
But
sir.
you said that 2 patients had hypopyon out of 100 in your slide.
Yeah.
So that is almost 2%, which is unacceptably high, isn't it?
In our cases, sir, now, yeah, it becomes, but if you pile up the data, now they are saying even 0.7%. Initial were 4%, initial results, but nowadays the latest is less than 0.7% chances of inflammation.
And those 2 patients, did they respond to treatment?
Yes, sir. So I will share that is a very interesting case. So end off, I did a vitrectomy. I put a silicone oil. It is a CRVO case. So after the SOR, I gave injection page next at the end of the surgery also.
These 2 patients
even after he had
are,
infection.
showing
So she had,
extremes of inflammation, right? But
Yes.
what about mild or moderate forms of inflammation that you came
oh,
across?
they are taken care of by post injection topical steroids only, ma'am.
Are you sure those hypopyon cases are only because of injection per se? On that particular day, you might have injected few other patients also.
Yes,
Whether
yes,
they
ma'am.
incurred that?
Though this is a very clean lady, no diabetes, no hypertension, chronic CSR patient. So no idea, man, why it happened.
Thank you, Dr. Balbir. That was a very good talk. I think, but with time, I think overall, I think we need larger data with Pagenex. Obviously, it works well, but what we basically, I think, as Sir was pointing out, I think the confidence level needs to go up with more robust and data with clear treatment protocols where everybody follows the same treatment protocol, and then we study and then we kind of safely use the drug more often. Thank you.
Thank you.
Anubhav, you are next. Please. Why I use aflibercept in wet AMD and DME? Dr. Anubhav Upadhyay is a consultant in ASG Jaipur.
Shall I start? Good afternoon, everyone. The topic for today is why I use aflibercept in my cases of wet AMD and DME. Myself, Dr. Anubhav, I'm a retinal consultant at ASGI Hospital, Jaipur. This is my disclaimer. So we'll start with what factors drive the key mechanism behind the pathogenesis of wet AMD and DME. So as we all know that VEGF-A is the key culprit along with other inflammatory mediators. It promotes vascular leakage, edema, causing inflammation and neovascularization. So even after targeting VEGF-A as targeted by brolucizumab and ranibizumab, there are other inflammatory mediators left which need to be addressed. So aflibercept, it has a multi-target action. It's a decoy receptor fusion protein, and it takes care of all the accessory inflammatory markers along with placental growth factor, galectin, and VEGF-B. And these are the currently available and approved anti-VEGF agents available. So we all know that aflibercept has always been a molecule of choice since past decade, especially in cases of wet AMD in all of our clinical practice. We'll have some look at some famous RCTs and the real-world experience. So this is the data from Altair, which was a multi-center randomized open-label phase 4 study in treatment-naive patients. So at the end of 2 years, the mean changes in BCVA from baseline in 2 weeks treat and extend arm was gain of 7.6 ETDRS letters, and in 4 weeks it was 6.1. Although the number of injections was 10.4 in both the arms. Another interesting thing is the proportion of the patients which were maintained at 16 weekly intervals at the final visit in 2 weeks treat and extend arm was 41.5%, and in the other arm it reaches to nearly 50%, it's 46.3%. Second most important thing is in Altair, in the year 2, the number of injections needed was less than 4. So the vision gains achieved in year 1 were maintained to week 96 with fewer than 4 injections in year 2 in both the treatment groups. Another important aspect is in the 2-week adjustment arm, 43.1 patients were capped on 2-week adjustment, and after the finish of the study after week 96, 41.5 maintained that period. So up to 96.2% of the patients extended to 16 weekly aflibercept maintained this interval to week 96 with aflibercept, which shows the durability of the molecule. Some data from View 1 study, at the end of 2 years, there was 10.2 letter gain. In View 1, there was 8 weekly aflibercept given. And there was an extension study period given, and the patients were prospectively analyzed after 3 years, and the name was given range. So range was a follow-up study of View 1 extension, and the vision gains were with aflibercept maintained through 5 years with continued proactive dosing as per study protocol, and after 5 years, there was a gain of 7.1 ETDRS letters. So let's see what real world experience has to say. So there was a real world study by Al-Mutasib et al. And it was just a replica, or the results were a replica of VIEW, because aflibercept was given at 8 weekly intervals, and the results in terms of gain of ETDRS letters was similar to VIEW, plus 8 letters gain was there, and 7 number of injections were given, which is exactly same as the VIEW study. And the real world experience from Moorfields and Jaggi et al., which was treat and extend regime, it replicates the result from Altair in the initial 2 years. And another important thing is, when the Moorfield patients were followed for year 3 and year 4, the visual gain was maintained, with the injection number becoming fewer and fewer in the consecutive years, which was 2.8 injections in the 4th year, according to the Moorfield data. Now, aflibercept as a choice for diabetic macular edema, we'll have a look at the RCTs and the real-world experience. So, the VIVID and VISTA study, there was rapid vision gains achieved with early intensive aflibercept treatment in year 1, and the result was maintained to year 3 with a reduced number of injections over time. So, at the end of year 3, in VIVID and VISTA, there was a gain of 11.7 and 10.3 ETDRS letter gain, and in VISTA it was 10.5 and 10.4. The point to note is that in the 8 weekly treatment regime, the mean number of injections given in VIVID was 4.5 in comparison to 8.7 in year 1, which is nearly half, and in VISTA the result is almost the same. So the patients from VISTA, after 3 years, there was a 2 years prospective study, and they were analyzed, which was named as endurance. So patients from VISTA maintained vision gains up to year 5 with continued aflibercept treatment, and through year 2 of endurance, 25% of the patients required no treatment, and 48% of the patients received less than 5 injections in these total 2 years. We all know about protocol T, and it has already been established that aflibercept is superior to ranibizumab and bevacizumab, especially in patients with presenting baseline acuity of less than 69 ETDRS letters or less than 20/40. After the 2-year period, there was a gain of 18.1 letters in comparison to ranibizumab, which was 16.1, and bevacizumab 13.3. The important thing is the median injections given in year 1 was 10, which reduced to just half 5 injections after the year 2. The slide's not moving. Okay. So let's have a look at the real-world data from Apollon. It replicates the data from VIVID study, and it shows that with early intensive treatment the first year, aflibercept can achieve RCT-like vision gain, which was analyzed in year 2. There was a gain of 6.5 letters, and with 11.3 injections. In Moorfields, the real-world experience, the patients from the cohort which was presenting visual acuity less than 20/40, in year 1, there was a gain of 17 letters. In year 2 and year 3, it was plus 11 letters gain. But the point to note is that in year 2 and year 3, there was a drastically reduced number of injections in comparison to year 1, with 7.1 injections given at year 1, 2.9 and 2.6 in year 2 and 3, respectively. So we'll compare with the newer anti-VEGF in our armamentarium with this with injection aflibercept. So this slide already shown by Saurabh sir has been shown already. So there is no vision gain with faricimab were non-inferior to those with aflibercept at the primary endpoint. This is a slide showing comparison with brolucizumab. In Hawker Harrier, only 39 to 45% of the patients were maintained on 12-weekly dosing with brolucizumab. One important point I would like to bring into notice is that being smaller in size and the higher molar dose being given, there is a very rapid effect, drying effect of brolucizumab is there. But despite the relatively high molar concentration of brolucizumab, its relatively small molecular weight means that it has a shorter intraocular half-life and it clears off early, and thus only 39 to 45% patients could maintain the 12-weekly dosing. This is the ocular safety profile, and we all know that brolucizumab has increased number of retinal vasculitis and occlusion cases. I would like to bring some clinical cases into you. Like this is the first case, a 60-year-old gentleman presented to an OPD serum DOV since 15 days. We can see that the right eye macula scarred, predominantly scarred CN with subretinal heme, and the OCT is disorganized. The patient was given injection razumab, and after the first dose, somewhat the restoration of anatomy is seen with resolution of edema. The hemorrhage is gone. Even the vision was improved by significantly. another dose of Razumab, there was not much significant effect, no resolution of macular edema, although the hemorrhage cleared, but there was no visual gain improvement. So patient was switched to injection aflibercept and it worked beautifully. There was clear restoration of the normal foveal anatomy and we can see the atrophied macula. There was macular edema drying was seen, no hemorrhages, and even the vision improved by one line. A patient was satisfied. In this case, this is a treatment naive case, right eye type 2 active CNVM. This is the OCT with lots of fluid, one injection aflibercept, and the fluid dried beautifully with some pockets left, and the patient was advised another injection of aflibercept. This case number 3, patient presented to us with right eye PD, already 3 doses of eccentrics being given. This is the pigment epithelial detachment which responded beautifully and the PD flattened. After the first injection, there is some amount of SRS still left, but after the second injection, there was no sub-RP fluid, and even there was restoration of normal foveal anatomy and vision improved beautifully. This is a case of moderate NPDR treatment naive patient, and he was given right eye injection aflibercept. We can see subfoveal cyst, big cyst, and it collapsed just after a month, and the vision was improved. And we can also see there was some resolution of hard exudates too. This is the case 5, 60-year-old gentleman, poor glycemic control, deranged lipid profile, already being injected with multiple anti-VEGF injections. And this is a chronic recalcitrant case, just like any other chronic DME with big cystic spaces and small NSD. Patient presenting vision was 636. After first injection, the cyst collapsed and NSD was gone, and there was a visual improvement. After the second injection, we can see the foveal anatomy being restored, and the cystic spaces, they collapse further. With further improvement, the patient is due for this third dose. And this is my final case for today. 52-year-old diabetic female, phakic patient, PDR post-PRP, well lasered, no NV, 5 injections in the past year. Last given 1 month back, patient presented with this OCT, subretinal heme, big cystic spaces. Patient visual acuity was 660. After first injection, cystic spaces collapsed, and after second, they further collapsed. Patient is due for his third dose. Vision also improved. That's my time for today. Thank you so much for the patient hearing.
Dr. Anubhav, I think you have brought out very clearly the effectivity of aflibercept or Eylea. But why I like Eylea more is because of its safety profile and maybe because of the schemes they offer nowadays.
I would like to invite the discussants for the next session, Dr. Bhuvan, Dr. Sangeeta is already here, Dr. Saurabh Arora to be on the dais. The next talk is by Dr. Bhuvan Chandna, Time to Look Beyond Anti-VEGF. It's a Roche-sponsored talk.
A very good afternoon to all of you. I would like to thank Roche and AIOS for giving me this opportunity to present. So I think it's very good now that we have a discussion on so many anti-VEGFs, and we have so many tools in our kit that we can handle different diseases with the different anti-VEGF. So I'll be discussing that now we have to look, the time to look beyond anti-VEGF agents, and this is my disclaimer. So the new molecule, that is faricimab, which came in around February 2024, it has got a dual inhibition of the Ang2 as well as of the VEGF-A. So how does this help? First of all, theoretically, and then I'll just show some cases in my practice that how I'm using it. So this is basically the molecule. It is a bispecific molecule which has got 2 antibody binding sites, and one of them is against the VEGF and the other arm is against the Ang2. So this is the first bispecific antibody which has been used for the eye and is designed for the eye. So this is made by a technology that is known as a cross-map technology. That is a molecule which has got 2 antigen binding sites, which is a patent for Roche, and they basically use it. So there are 2 fragments in an antibody, the FC fragment and the variable fragment, that is the Fab fragment. The and there is a heavy chain and a light chain. So they just use this technology to create this bispecific molecule, which I just stated as against the Ang2 and the is an anti-VEGF. So what is this role? So again a bit of theory. What is the role of angiopoietin in maintaining the homeostasis of the retinal vessels? How does it maintain the integrity of the retinal vessels? So this is basically the angiopoietin pathway. We have got the Ang1, which is considered as the good, you can say that is the good Ang. It binds to the Tie2 receptors, that is the tyrosine kinase receptor, and both of them, they help to maintain the integrity of the vessels. They help to promote good endothelial tight junctions. They help the pericytes to remain, they prevent the fallout of the vessels, and they prevent neovascularization and maintain the integrity of the vessels. But however, the other part is the Ang2, which you can say is like the bad one or the villain, which is the one if it increases in diseases like diabetic macular edema, RVO and AMD, and that will compete with Ang1 for binding to the Tie2 receptors. And what will that happen? That will lead to increased endothelial loss of pericytes, increasing vascular permeability, increasing inflammation. So the main thing here is with this salt, we are not only targeting the VEGF that leads to neovascularization, but also controlling the component of inflammation and fibrosis, which I'll also discuss further. So this is a study which was done in the mouse model, and they said that you can see the presence of leukocytes when they induced a uveitis in the mouse model. Leukocytes were seen within the retina, and when we treated it with anti-VEGF-A or anti-Ang2, then still some leukocytes were present. But when we treated it with a combination of anti-VEGF and Ang2, then there was a very significant difference in the absence of leukocytes within the retina. Hence it has got a definitive role in controlling of the inflammation, that is the inhibition of the Ang2. So as I said, it causes sustained inhibition of both Ang2 and VEGF-A. It leads to much more vascular stabilization, reducing the leakage and inflammation, and it also has an anti-VEGF action that prevents neovascularization. All these things combined lead to a longer duration of action, which we have witnessed that with a slower but a longer duration of action up to around 16 weeks in about 70% of the patients in the phase 3 clinical trials. So as we all know now, most of the retinal diseases are multifactorial diseases. They need repeated frequent injections. So our main aim is to increase the treatment duration and reduce the patient load, and also tackle the multifactorial part of the diseases. So as we can see that both VEGF levels as well as Ang2 levels are increased in AMD patients, RVO, diabetic retinopathy, and as well as diabetic retinopathy with PDR patients. So we have to, with this molecule, we not only target the VEGF levels but also the Ang2 levels. So faricimab causes rapid and sustained intraocular suppression of Ang2 and VEGF-A up to 16 weeks in the phase 3 trials in both neovascular AMD as well as DME patients. So you can see that first there is a rapid fall in the Ang2 and the VEGF levels, which gradually continue to increase, and the peak again it reaches to the previous level at around 16 weeks. So the action is much more slower and sustained, and hence it needs a loading dose followed by a treat and extend protocol. So this is the suppression of faricimab, showing the suppression of Ang2 in comparison to aflibercept in the phase 3 clinical trials. So you can see that in 4 and 8 weeks there is almost a negligible amount of Ang2 which is present, which is below the quantifiable levels. However, with aflibercept, if you see that at 4 and 6 levels with aflibercept alone, the Ang2 levels tend to increase after 4 to 8 weeks with treatment with aflibercept. So what is the potential benefit of this dual inhibition is? It leads to vascular stability, as I said. It reduces the inflammation. This has been shown in phase 3 trials in both DME and AMD. I'll just summarize those trials. And this leads to much more possibility of increasing the duration of the treatment and decreasing the number of injections, as well as the decreasing the overall treatment burden on the patient. So these are the clinical trials. First for neovascular AMD, I think we have been discussed by the previous speakers also. about all the anti-VEGF, the Tenaya and Lucerne, in which they showed a response that was equivalent to or not inferior to aflibercept, and then it has been extended. The only benefit is that the number of injections which were needed were less as compared to aflibercept with faricimab. Similarly, in DME, the Yosemite and the Rhine study was done, and they followed a treat and expand or a PLI regime in which they gave first monthly injections, and then after 6 injections then they increased the duration. So this has also shown response that are almost equivalent to aflibercept. However, the number of injections which are needed were quite less. So these are the trials which are showing a good effect of faricimab. Now I'll just discuss few cases and how did I start using it. So this was one of my first patients. So this is a patient, he is a doctor himself. He received ranibizumab for a treatment. He comes from far, but there was no response, so we shifted to aflibercept. And his vision improved to 6/9. But the problem is that his vision kept on ranging from 6/9 to 6/18. After every 6 to 8 weeks, there was a recurrence of this subretinal fluid. So after receiving multiple aflibercept in December 2023, when he presented to me, I gave him an aflibercept injection because there was this fluid. In January, there was some amount of fluid which was still present, and the vision was also 6/9 parts. And at this time, at the end, the faricimab had came. We were waiting for that drug. And I gave him a Vabysmo injection, and after a single injection, there was complete drying, which was expected, which was also there with aflibercept, but there was a recurrence at 6 weeks. So I did a OCT at 6 weeks, so there was still no fluid, but since this is a switch patient, I did not give a loading dose. I gave him a second dose at 6 weeks, and after giving him 2 doses, this is the OCT at 14 weeks, and the patient is doing absolutely fine. He's on a treat and extend regime. He has gone up to 12 weeks. The vision has improved to 6/6. So what I observed in this, not only there is complete drying, but also the advantage is that it probably has a role in improving the outer layers of the retina. Probably because of the ANG2 effect, there is a decreased incidence of scarring which is present in some of these patients. So this is another patient who was on treatment on aflibercept. His right eye, aflibercept was given, treat and extend, and is absolutely fine, is doing great, does not need any further injection till date. However, the same problem in the other eye. After every 6 weeks, there is this recurrence of this subretinal fluid, these small PEDs, the SHREM is there, the PD height increases, and the vision deteriorates by 2 to 3 lines. So again, in this patient, in January, I gave him an injection in February. He presented in January, there was complete drying. But after 2 weeks again, he presented in the first week of February. There was this recurrence of this fluid. Again, you can see that the PD height has started to increase, and this is the time I gave him a faricimab injection. And following 6 weeks again since this is a switch patient and the patient was doing fine up till 8 weeks, I decided to give him a faricimab at 6 weeks. So this is at 12 weeks, this patient was absolutely dry. I decided to go for, rather than a treat and extend, on the PRN regime because this patient has received several injections. Although he needed the injection at 16 weeks, he is getting injections at 16 weeks. And I am shifting something between a PRN and treat and extend. But again, this is the second case which was getting a recurrent fluid with aflibercept, but however with Vabysmo, the duration of dryness has increased by about 8 weeks. So this is a treatment naive patient. So this patient is an old patient. He earlier had CSC and there was no problem. The CSC had gone away, but one day he presented with this vascular membrane, which was also seen on an Octa. I don't have the images. There is a PD, there is a double layer splitting sign on the OCT, and there is presence of subretinal fluid with a well-defined AVN which was present. And after a single injection of aflibercept or faricimab, there was complete drying, which is also observed with other anti-VEGF agents. But the good thing is that the PD height also reduced. In this patient, I decided to follow the normal protocol of giving a loading dose. So this is following the first loading dose and the second loading dose. And 1 month after the third loading dose, the patient is doing absolutely fine and has a dry macula. So this is another case. This is a chronic case. So he's a one-eyed patient. There was some scarring, some retinal fluid. So I offered him Vabysmo. The patient was very keen for treatment, although such cases do not improve. But there was some intraretinal fluid there, some retinal thickening. After single injection, what you can observe is there is an improvement in the contour, and also the scarring amount has gone down. The neovascular complex has reduced in size. So this is following 8 weeks, and this is the last. As I said, the outer retinal contour tends to improve. There was an improvement from 3/60 to around 6/36, and the patient is extremely happy with the treatment. Just 2, 3 slides more. So this is a case of DME. So the patient has received multiple aflibercept, left eye also Orzodex, and this I just wanted to state, this is a very non-compliant patient. The moment he gets better, he stops coming. So I decided to give a faricimab, and after a single injection of faricimab, there was a significant reduction in the cystic spaces, although not completely gone. Unfortunately, this patient is very irregular, has not come for further treatment, but whenever he comes, I'll come to know how the future response was. But after 4 weeks, there was a very good response by treatment with faricimab. Another DME patient, single injection faricimab, complete drying and a marked improvement in the contour of the retina. So this patient has not required any further treatment and has a good control of his systemic status, and with one single injection went fine. This is my last case, so just wanted to highlight few I've used in many cases. So RVO, although it is not approved in India, but I gave faricimab looking in it. So there is some CME, this is a HRVO case. So after single injection of faricimab, there is complete drying, which I think will also be achieved by other anti-VEGF agents. But the best part about what I observed is that there was almost complete disappearances of these hemorrhages after 3 weeks after the injection, which is not usually observed clinically with other anti-VEGF or if we observe. So almost all the hemorrhages have disappeared and there is complete resolution of the macular edema. So you have to be careful in such cases just to look out for the development of NVI, because I think we delay these things. I think that is a separate discussion. So just to conclude, I think we presently need a drug which is acting long, which is much more sustainable, and it should be safe. I should have a sound sleep after giving that injection to reduce the treatment burden. So I think it has shown a very good response in patients who are not responding to aflibercept or who are dependent with aflibercept, or have got a tachyphylaxis who were initially responding and then the duration reduced to 4 to 6 weeks. So we probably get a better response and increase the duration. So the initial results with faricimab are very encouraging for me in both AMD as well as PCV and DME. So thank you.
Much, Dr. Rohana. Can you elaborate on that statement that in switch patients you don't give a loading dose?
Yeah, sir. So see, a switch patient, sir, if I have given a dose of probably ranibizumab or aflibercept and there is no response, so probably then if I shift, I will give a loading dose. But if I am giving aflibercept and I am getting a response and I am able to increase the duration to maybe 8 weeks or maybe 10 weeks, so I don't think it would be justified in that patient to give a loading dose, because that patient is already on 6 to 8 weeks, and if I'm asking him that I want to shift you to a better drug, but I'll give you monthly injections, so probably I think neither the patient will be convinced nor I will be convinced to use that drug. So my main aim is not using a loading dose in such patients. I usually keep a target that when I'm getting a drying with my initial anti-VEGF, if it is 6 weeks, then I would like to observe for at least 6 weeks and then treat at 6 weeks even if it is dry, and probably do a OCT again after 6 weeks and then try to increase the duration as a treat and extend. But if there is no response, and a switch is different, if there is no response at all after 3 injections or 2 injections, then I do a switch, then I give a loading dose.
I do agree with that, because if it would have been a treatment knife, then probably the loading doses they work. In these kind of cases, yes, we can go with PR. Nice presentation, Dr. Bhavana. Thank you very much.
Sir, I also see the time it acts. When we give the injection, the first time we see the action of the drug, the faricimab is slightly on the higher side, means we see the action after 2 weeks, something like that.
So I absolutely agree with you, Vinod. I think with faricimab what we are observing is that the action is much more slower. But they have a loading dose of 4 injections, that is what they state. So in my clinical practice, sometimes I try to delay the injection by 2 weeks and give a loading dose maybe at 6 weeks. And I even try not to give 4 loading doses, but I think 3 loading doses would be sufficient. But I think the concept of 4 loading doses is that they want to go to 12 weeks directly. So if you are giving 3 loading doses, then probably you will go to 8 weeks and then 12 weeks.
So have you tried that?
What?
Giving 4 and then extending to 12?
No, I have not tried it yet. So I am giving 3 injections and then I go to 8 weeks. But the recommendation is give 4 injections and then go to 12 weeks directly.
Yeah, I think
but
exactly.
I would definitely like to try it, and probably I think few of my patients have enrolled. Since we are getting those in government panels, so probably in those patients I would like to give 4 injections and then increase the duration, because cost is a major factor.
Yeah, because this is exactly what I was just talking to Dr. Vishal, that at least with these high-end injections like aflibercept and faricimab, I think if we all start following a particular standard pattern, because with these, usually these patients would also be more compliant. So then we would have more robust data from our country as well. So which could be more collaborative, you know, and.
But sometimes I think again the problem is the cost, you know, like giving 4 injections, although they have a patient support program, but the cost increases very.
Increasing.
So I think we have to do a personalized approach for every patient.
And initially we have been using, you know, all patients are switch patients only, most of them. Like, you know, we need to switch over to the naive patients more often because this all data is of naive patients. So that is a big difference that, you know, we are underestimating the drug probably.
I think naive patients will respond much better.
Much better, exactly. Even I believe so. And just to add on one thing, like you just said, right, there are hemorrhages which probably, you know, disappeared much better in that patient. I had similar feeling with even heart exudation. So even heart exudation diabetic patient had, you know, absorbed beautifully in my few patients.
Yeah, I think there are studies and I have also observed it tends to regress the disease process of diabetes if you continue with the injection. The vascular patterns and some of them have also improved.
Yeah, I think that.
But that is even observed with aflibercept. There are reports with
kind of.
aflibercept
But
also.
the kind of absorption was a little more faster, I think probably, yes. Thank you.
Thank you.
Next, we invite Dr. Vishal Agarwal. He would be talking on eyes on Vabysmo, interesting cases in NAMD and DME by Roche.
So I'll be very brief and about the theory part and you know jump very shortly to the real world experience and our different interesting cases. The theory part and the pharmacology has been already been well elaborated by Dr. Bhuvan. So as we know, as a retina specialist, day in and day out, the most common diagnosis we make is NAMD and DME, which requires sustained and effective treatments. But both these terms, sustained and effective, is very difficult to achieve in these two conditions, primarily in our country because of the economic constraint. And even if we remove the money out of the equation, we all know that a substantial number of patients do not, respond to anti-VEGF from the first injection itself. And that prompts us to think that there are multifactorial causes for the disease, which includes an inflammatory component. So, and that is where, this whole saga and the story of Ang1 and Ang2 comes in. So, and we have ample evidence now that the angiopoietin pathway maintains vascular stability and homeostasis under physiological conditions. And the Ang2, as Dr. Bhuvan said, is the bad Ang, and it promotes vascular instability by blocking Ang1 and Tie2 signaling pathway. And both Ang2 and VEGF levels are upregulated, although in a different magnitude in different diseases. As you can see in the graph, it's maximum in RVO and it's quite increased in AMD and diabetic retinopathy. So Vabysmo was launched in India this year, January, and this is the first bispecific molecule to target Ang2 and VEGF using their innovative patented cross-map technology. And it has been seen that both Ang2 and VEGF concentrations, return close to baseline at 16 weeks post-dose. And the most important thing is that 8 weeks post-dose, you can see there's almost a separation of 80% of Ang2 concentrations in Vabysmo. So combining, the bispecific inhibition, you can see what we need to achieve. The first slide, the sustained and effective treatment, sustained inhibition of both Ang2 and VEGF-A with the vessel stabilizing effects of dual Ang2 and VEGF-A inhibition leads to prolonged pharmacodynamics, and that is what we need. Every drug is working fine, whether it's aflibercept, brolucizumab, ranibizumab, but what we need is less frequent injections. And these were the trials which led to its approval. Coming to NAMD, it was the TENAYA and Lucerne trial. And the important thing about this trial as compared to the comparator molecule aflibercept was that after the initial loading doses, there was no fixed dose regimen like in aflibercept. There was, Q8 injections till the end of the study. Here, the treatment was, curated as per appearance of new hemorrhages, increase in central subfield thickness, and decrease in BCVA. So these trials were, more close to what you practice in your clinics and what your regimen is in the real world experience. And although, as mentioned by my colleagues and in the previous slides, the vision gain was comparable to aflibercept, but the important thing is that the median number of injections was almost half as compared to aflibercept in the second year. And the reduction in central subfield thickness was also achieved in almost half the number of injections that of aflibercept. And the important thing is that almost 60% achieved of these patients Q16 dosing, and almost 80% achieved Q12 weekly dosing. So now coming to the real world evidence, and why is it important to us? It is important because in RCT data, the patient population is homogeneous, and in our clinics, we don't look at the lesion size, the age group, and the scarring level. The patient comes with fluid, decrease in vision, we inject. So it's a more heterogeneous population in the real world scenario. In the routine clinical practice. And there are a number of real world studies already published. So our experience since January is we have injected more than 115 patients. The total number of injections has been more than 200 for Vabysmo. Coming to cases, I'll share a few cases of NAMD and DME which are interesting. This particular gentleman came with a lot of hemorrhage and subfoveal fibrosis and a recent decrease in vision. And this is after multiple anti-VEGF injections. And you can see this OCT 20 weeks post 2 Vabysmo injections. Of course, the visual acuity improvement was modest because of the central scar, but the patient is maintaining the same vision without any recurrence after 20 weeks after 2 Vabysmos. This was a particular aggressive case of RAP, and multiple anti-VEGF injections were given. Fresh bleed was there with fibrosis. And this lady, received 3 loading doses of Vabysmo. The vision improved to 6-12 parts. She came recently, 15 days back, and you can see the fluid is still not there. And you can see the serial OCTs also. And the patient is maintaining the vision 6-12 parts without a need of the 4th injection, even after 20 weeks. Again, this slide is just to show what had been discussed a couple of minutes back, that this patient was, is a patient of focal CNVM with fluid, and you can see the subretinal fluid. And the patient came, he was on brolucizumab, and after 2 weeks, the patient came to us that you have injected such an expensive drug, but there is no response. But as we were told by the company people that this drug takes a little more time than the other drugs, and the right side OCT is after 4 weeks, and you can see the complete resolution. So it takes a little time, and you have to tell the patient in hand that if you have received aflibercept and brolucizumab, it might take a little time, but the final result will be the same, and perhaps a little more longer acting. So coming to aggressive cases, this was a patient of massive subretinal bleed. You can see the intraretinal and subretinal fluid with hemorrhage. And at that time, you were contemplating actually subretinal TPA for this patient, but in January, the drug was just launched, and we gave the option of Vabysmo. And this is the amount of resolution you can see on the right side fundus photograph and the OCT below it after 4 weeks of a single injection, and the patient improved to 618 parts. Of course, we gave 3 more injections, and the patient is maintaining 618 without a recurrence of hemorrhage or fluid. This is a one-eyed 80-year-old gentleman. You can see the intraretinal subretinal fluid and the PED. And after 3 Vabysmo injections, this is 16 weeks post 3rd Vabysmo. You can see the serial OCTs. There is a flattening of not a flattening, but there is a reduction of the PED height and a complete resolution of the intraretinal fluid. And the patient is maintaining around 612. This was a 35-year-old software engineer from Gurgaon, and she was, having multiple injections with recurrence after monthly injections of ranibizumab and aflibercept. And she was very frustrated and, depressed at her workplace as well as her personal life. And this one was the first patient which I injected Vabysmo, one of the first patients. And after 2 Vabysmo injections, now she is 20 weeks post the 2nd injection, and the vision is 6/6, and there has been no recurrence. And you can just see the macular anatomy, and it seems that she didn't have any fluid at all at the first place. There was a complete resolution with the restoration of the foveal anatomy. Again, a sub-RP bleed and a lot of fluid, large PED, and multiple anti-VEGFs given elsewhere. There was a fresh bleed. The vision dropped to hand movement. And this is after 3 injections, loading doses of Vabysmo, 16 weeks. The second OCT is after 12 weeks, and they were the third OCT is around 20 weeks post Vabysmo, 3rd, and there was a recurrence after 20 weeks. So the patient maintained the flattening of the PED without any recurrence of the bleed at 16 weeks. But at 20 weeks, we injected the 4th dose of Vabysmo because there was a recurrence. This is a case of subretinal bleed with a PD, with multiple anti-VEGFs elsewhere. Again, 20 weeks post-Vabysmo after the loading dose. Any of these patients did not require the fourth injection, which I'm mentioning here. The vision improved to 612, still maintaining to 612 parts without the recurrence of the bleed. You can see the serial fundus photographs and the OCTs, and there is no recurrence of the bleed or the fluid in these cases. Again, a thumb-shaped PED, a lot of bleed there, a typical PCV patient, and multiple anti-VEGFs, brolucizumab and ranibizumab given elsewhere. And this is a switch patient, and after two doses of post-Vabysmo, this is the 20 weeks follow-up. And here you can see the almost complete flattening of the large PED with the resolution of the bleed. As Dr. Bhuvan mentioned, the thing which I have noticed here with Vabysmo as compared to the other molecules is that the reduction in the bleed, whether it's RVO or whether it's CNVM with bleed, is huge. It's much better than the other drugs. And the patient is maintaining 6/9 after 20 weeks of 2 doses of Vabysmo. This is a secondary CNVM post pattern dystrophy, bilateral symmetrical lesions. The patient, there is a central foveal scar. The patient presented a secondary CNVM with fluid, and this is a complete resolution after 2 doses of Vabysmo. Third dose has not been needed till now. Again, these are aggressive cases, and these are all switch patients. A lot of STEM and a PED and a lot of bleed here. You can see in the serial fundus photographs. And this lady required 4 loading doses of Vabysmo. The presenting vision was finger counting 3 meter. You see the last OCT on the right side, the bottom OCT, and you can see the first one on the topmost OCT on the right side. And you won't believe that this is the same OCT of the same patient, because there is a complete resolution of the bleed, there is complete flattening of the PED, and there hasn't been a recurrence for the past 8 weeks till now. Coming to DME, I'll just share only one interesting case, because this is what is interesting. This patient is our own patient, and he has received 13 aflibercepts and 2 Ozurdex, and this case exemplifies the case of refractory DME. And finally, we gave him the option of Vabysmo, and 4 weeks post Vabysmo, 4th injection, you can see the serial OCTs on your right side of the slide, and the vision improved to 612. There is no recurrence, and there's a complete dry macula. So just to sum up, almost all the patients, the 100 patients, were equally divided between CNVM or DME. And we now have a study of our own intravitreal faricimab for chorioretinal disorders, evaluating real-world efficacy and safety in India, the INFO study, and we have sent it for publication. And here you can see that the logMAR BCVA, whether the parameter is logMAR BCVA or whether the parameter is central subfield thickness, there has been a significant decrease from the baseline, whether it's in treatment-naive patients or switch patients or refractory patients. So to conclude, there is greater numerical gain in vision after even 1 injection. And majority of the patients, achieved stable, reduced or resolved fluid, including subretinal bleed. And there is rapid improvement in all the parameters, whether it's PED height or whether it's intraretinal fluid or subretinal fluid. Although this, this is evolving data, we have a modest sample size, and the follow-up, duration is small. But we'll be more wiser maybe later next year or, early next year, when all these patients which we are injecting now come into that the magical Q16 figure which the company claims. And if my patients personally, if I feel, if my DME or NMD patients, and even if 50% of these patients, require 3 or 4 injections in a year, I think this drug is a game changer. Thank you so much. And I all invite you to Roscon, Udaipur from 8th to 10th November, the annual conference of Rajasthan Ophthalmological Society. Thank you so much.
An excellent presentation, and the house is open for discussion.
Very fascinating pictures I saw, and just a couple of comments. So in a lot of your cases, I saw that the PEDs were really high.
Yes.
So that was what was very interesting about a lot of your cases.
Yeah.
So did you have RP RIP in your cases?
Not yet.
Not yet.
No, yes.
And more than 200 cases.
More than 225 injections and around 115 patients. So yes. 225 injections of approximately 115 patients. Yes.
So, what would be interesting to see is that, with faricimab, maybe because it acts in a slower way,
yes,
we are seeing less RP RIP than we see with brolucizumab.
Yes.
You know, because on one hand we had, you know,
Because,
RP rips in the series which was presented here by Dr. Balbir, where, you know, and we have seen also, you know, RP rips. So maybe it's a very, it hits very hard. So especially in these cases which have a very high PED or a tall PED.
So rapid
maybe,
drying is not
yes,
required.
rapid
in
drying
that,
is not,
yes.
you know, indicated. So I
Recommended,
think
yes.
faricimab may be, you know, scoring over there. The other point was that I also felt that there was a resistance to injection which decreased once we keep the injection outside. How do you manage that, like with faricimab?
You mean to say the injection procedure?
I mean the viscosity of the
So
drug.
yeah, so the first couple of injections we were really troubled because it's really hard to push because it's very viscous. So now what they have told us and what we follow now is that 30 minutes before we remove it from the refrigerator, the injection, and now it's still a little more pushier than the other drugs, but still makes life easy rather than if you just freshly take it out from the refrigerator, then it's really viscous.
Right.
And the second thing, what you mentioned is every patient who you are switching from brolucizumab and aflibercept, you have to mention that this is a slow-acting drug. Do not come running after me after 10 days because they'll eat your head. It's an expensive injection. They'll say that what was the difference? It's not acting even after 2 weeks. So you have to be a little patient at 4 weeks.
Also, did you see any, IOI or vitritis after any of the cases?
No. Okay. No AC cells, nothing till now.
No vitreous cells?
No vitreous cells also.
Because we look for vitreous cells and we did have a couple of cases. My series is much smaller than yours. But it's after that that, I became more cautious, although none of them, turned out to be serious. But they were vitreous cells and,
But what was the follow-up time? When did you see those vitreous cells?
So they came up maybe about 2 to 3 weeks following the injection.
So you call them for the regular follow-up, but they complained a decrease in vision?
No. So yeah, that was interesting that in one of the patients, the patient reported with floaters. Okay. So that patient did have, a history of Paginex injection in the past.
Okay.
So in fact, I put this up in one of the, online meetings where you were also there, and I think we had the faculty from abroad who said that, if it's a Paginex, injected patient, they are primed for IOI.
That could have been a compounding effect with
the but the thing is that I had a patient who was Paginex naive, who had, vitreous cells. Of course, it resolved. But again, this just goes to show that we have to be a little careful with these, high molality drugs. And the chance of IOI, although not serious, is always there, and we have to be on the lookout for that.
So what I'm trying to tell you is that all these drugs are very good and they have a drying effect, very good. And most of these drugs are acting till 12 weeks, whether it's brolucizumab or aflibercept. But this is the drug which I have felt can be extended till 16 weeks in almost 50% of the patients. And the second point is what I showed you, intentionally I kept those cases where there was a lot of subretinal and sub-RP bleed. And this drug is especially effective in, resolving that bleed. The mechanism I don't know, but it's really effective in, resolving and drying up that bleed.
It was nice presentation, and even I do agree, whatever I have used Vabysmo, it's like slow acting drug. But if we look at the IOIs or any reactions or vitreous cells, I hope every one of us might have experienced with one or the other drug, one or the other time. So it's not compulsorily that it's coming with particular drug, might be a patient's perspective. From patient's perspective, the systemic diseases and all, they will also play a role for that.
Also, does anyone inject dexamethasone like Dr. Balbir was, suggesting with brolucizumab? Are you guys injecting dexamethasone?
The chronic CNVMs with the scar and with refractory fluid, I do inject.
No, is it for IOI? Because in the West, some people were, kind of co-treating with steroids preventively to prevent IOI. Any of you?
You mean prophylactic dexamethasone along with the injection?
Yes, or topical steroids for that matter. Anybody uses topical steroids?
Steroid, but I do at least give, sometimes I do give Tovadium with Paginex, maybe. Dex or something.
Yeah, even I use
topical dexamethasone.
Topical, slow, very short.
But then again, the question is, I'm not criticizing any drug. Every drug is very effective. When you are in a private practice and not in an institutional practice, why take a chance of a drug which has a significant amount of IOI? Whether it's not proved in the Indian population, okay. But most of the reports of adverse effect and risk mitigating algorithms are on brolucizumab. So are you willing to take that chance when the price range is the same, the effectiveness is the same? So that is a practical question we have to answer.
I don't think that Paginex is on the same platform as Eylea and Vabysmo.
Yes.
It's not. So
Yes.
I think it's, and probably, I don't know whether it'll achieve that ever.
Yes.
So there is no doubt that, we all agree that there is some issues with that. So, but then it is a drug, and it is a drug which does work at some times. It does. So, and with Vabysmo coming in, maybe, things will change.
I think it
Can
all
I
works.
ask what are the clinical characteristics or the OCT characteristics that guide you to what anti-VEGF to choose from the entire list of drugs available?
So, madam,
What
that
is
is
the
very
treatment
difficult to,
naive patient?
yes, very difficult to say. So, there are, there are two categories of patients. One is who cannot afford, who do not have medical insurance, and they are mostly injected by all of us, by biosimilars, maybe by Avastin. These drugs also work wonderfully. What we are talking about here is who have a medical, most of the, 90% of my patients had medical insurance. They cannot afford, 3 or 4 lakh rupees treatment. Okay. So, if they pay by cash, that's very difficult. So, all are covered by medical insurance. Then you can compare aflibercept, brolucizumab or faricimab. So, these three drugs are on the expensive sides, and they all are effective. So, you cannot compare all the patients, because majority of the patients are still biosimilars for everybody's practice.
Yeah, but I just wanted to add one thing for what Dr. Saurabh had. I don't think giving Tobar-DM or giving a DEXA implant is of any use with Vigenax, because every patient will not develop it. No. I think a better practice is that you follow up the patient at 2 weeks, 10 to 14 weeks when there is a risk, and if develops, then probably we should act by these steroids.
And do not repeat it before 1 month, before 6 weeks. Before 6 weeks.
Before 6, Vigenax is a drug which mostly we follow PRN regime with the first drug.
Even I do agree, because we don't have so many IOIs. So that's a good point, that we should follow up the patient very frequently.
Yes.
So repeatability after 6 weeks, I would say that there were those 2 trials which were kind of discontinued, because in that they were trying to inject more frequently. But Merlin. I would say 2 to 3 months, because I had a case of occlusive vasculitis, and that the difference between the doses was 3 months.
Still it had.
Still after the 2 weeks after the third dose.
Okay, can we go next?
I think it's more safer to be.
But the fortunate thing was that
PRN,
the macula was not involved.
I follow PRN.
Yeah.
I mean,
So fortunately, the macula was not involved. But yes, I am very, very careful about, and in that patient, the patient was demanded for that, injection, and the Eylea injection prior to that was giving rise to fluid every 4 to 6 weeks. So I didn't have a choice. Yes. There was nothing else which I could offer to the patient.
Yeah. I think wonderful presentation, Dr. Vishal. I think this is a never-ending thing about the 3-4 injections. I think let's go to the next talk. And yes, for the next talk, I would like to invite Dr. Charu Malik for anti-VEGFs and diabetic macular edema. Not there.
Okay.
Do we have Dr. Charu here? No.
I don't think so anymore.
Dr. Vaibhav Bhatt? Yeah. So Dr. Vaibhav Bhatt would be speaking on New Kid on the Block, our experience with intravitreal faricimab.
So good afternoon, everyone. At the outset, I would like to thank AIOS for giving me this opportunity. So I'll be starting with my presentation, our experience with faricimab, New Kid on the Block. So most of it is covered by Bhuvan sir and Vishal sir. So it is composed of 2 heavy chains and 2 light chains. It is a molecule with 2 targets. One ligand binding arm binds to VEGF-A and the other binds to angiopoietin-2. And it has a modified FC region which decreases its systemic exposure, which thereby reduces its pro-inflammatory effect. So all of this is covered. We all know that Ang1 binds to Tie2 receptors, and normally in a healthy retina, Ang1 outnumbers Ang2. But in cases of neovascular AMD and DME, Ang2, it competes with Ang1 and binds to Tie2 receptor, and thereby it downregulates the phosphorylation, and thereby it increases inflammation, it increases permeability, and the VEGF-A binding to VEGF2 receptor leads to neovascularization. So faricimab, as we all know, is capable of binding to both VEGF-A and Ang2 without any binding to Ang1. So we've all gone through all these clinical trials, AIOCMT and RHINE, and they concluded with a durability of almost 62% patient can be injected 16 weekly. Tenaya and Lucerne were also done, and they also concluded that around 63% patient can go up till 16 weekly dosing. So coming on to our cases, our first case is a 55-year-old female with a bilateral PDR. She has a left eye CSME. 3 settings of PRP laser had already been done. She had received multiple anti-VEGF injections elsewhere. Came to us, we started with anti-VEGF, aflibercept were given, ranibizumab was given, and then we shifted to Ozurdex. So this is a representative OCT showing CME. So at this juncture, we gave Ozurdex to the patient. 4 weeks post-implant, the CME had gone, it had all resolved, but at 16 week, it had come back again. The recurrence was there, and this was the usual pattern with Ozurdex. So at that time, we offered an alternate to the patient, and faricimab was injected. So as we can see, 4 weeks post-injection, the CME had resolved, maintained at 16 weeks, and there was a recurrence at 24 weeks. So second case is a 79-year-old male with the right eye neovascular AMD CNVM. Patient had received 4 aflibercept injections. So as we can see that this IRF with CNVM, aflibercept was given and it resolved after 4 weeks. But there was a recurrence at 8 weeks. So at this point, faricimab was injected, and as we can see, it had resolved well after 4 weeks, and it maintained till 8, and there was a recurrence at 12 weeks. So the time period, so the duration had shifted from 8 weeks to 12 weeks. A third case is a 69-year-old female with a left eye PCV. A total of 20 injections has already been given to the patient. We have tried everything, ranibizumab, aflibercept, brolucizumab. And here we can see a representative OCT seeing the PED with SRF. Aflibercept was given. 8 weeks post-injection, there was a minimal kind of response, or there was a recurrence. Patient was not followed up at 4 weeks. Patient directly came to us at 8 weeks. So again, we injected aflibercept. At 4 weeks, we can see a flattening of PED, and SRF had completely resolved. But at 8 weeks, again, there was a recurrence. So at this point, faricimab was injected. And as we can see, 4 week post-injection, this complete flattening of PED and SRF had completely resolved and maintained at 12 weeks. And then there was a recurrence at 16 weeks. So the patient had shifted from that 8-week recurrence period to 16 weeks. Our fourth case is a 72-year-old female with the right eye neovascular AMD CNVM8. Aflibercept had been given to the patient. Here we can see CNVM with SRF, 8-week post-injection. It had completely resolved. 12 weeks, again there was a recurrence. And again, aflibercept was given. So again, 8 weeks, that was the pattern. 8 weeks, it was all going well, and there was a recurrence at 12 weeks. So at this point, faricimab was offered, faricimab was injected. And here we can see that 12 weeks post-injection, patient is maintaining the dry state. But there was a recurrence at 16 weeks. Our fifth case is a 79-year-old male with the right eye neovascular AMD scarring CNVM. Patient had received 8 injections. So here we can see that the injection was given. Patient was followed up at 8 weeks. There was minimal kind of response. Again, we injected. Again, there was a minimal kind of response. So after 4 injections, the patient settled down. PED had gone down, SRF had gone down. But at 12 weeks, again, there was a recurrence. So at this point, faricimab was injected, and patient had a complete drying at 4 weeks, maintained at 12, 16, and there was a bit of recurrence at 20 weeks. So our sixth case is a 51-year-old female with a left eye PCV. Patient had received loading doses of aflibercept, monthly consecutive doses, and 4 week post third injection. Patient was doing well. Patient lost to follow up. Then came after 6 months with the PED and SRF. At this point, faricimab was given, and at 4 weeks, we can see that the PED is still regressing. SRF had completely resolved, and at 8 weeks, that PED has completely flattened out. Our seventh case is a 63-year-old male, right eye neovascular AMD scarring CNVM. A total of 10 injections had already been given to the patient. So here we can see the IRF. Aflibercept was given. 4 week post injection, completely dried. Then there was a recurrence at 8 weeks. So we again injected with aflibercept, and the pattern followed. 4 week post injection, there was complete drying, but recurrence at 8 weeks. So at this point, faricimab was injected, and as we can see that the patient has maintained the dry state at 8 weeks, and it's still on follow-up. So summarizing my presentation, our experience with Faricimab has been in patients who have received other anti-VEGF agents previously and showed recurrence in shorter time intervals. PD regression in PCV is significant with durability varying from 8 to 16 weeks. Equivocal response, what we have found in DME cases, and the durability in neovascular AMD varies from 8 weeks to 16 weeks. So concluding my presentation, anti-VEGF molecules inserted within vitreous cavity have a lifespan. It's a challenge to obtain a perfect molecule which is capable of stabilizing the disease process as well as sustaining its efficacy to a suitable duration. Innovation, clinical trials, and our own clinical experience guide us to implement the best for our patients. Thank you.
Yeah, very wonderful presentation. Again, okay, so I mean, have you tried the loading dose in any of these patients?
Yes, sir.
The loading dose?
No, sir, we haven't tried any loading doses.
Because
yet.
all the switch patients
Yes,
probably.
sir, yes, sir.
Yeah, so
all patients had received anti-VEGFs previously and then we switched to Faricimab.
yeah, so
because
that
of
is,
the durability and other
so
issues.
we were talking the same thing, that the concern is that the switch patient, it's difficult to start the loading
Yes,
dose.
sir, yes, sir.
Yeah. Anything?
Ask you one thing.
Yes, sir.
Many of our ILIA patients and Vabysmo patients are on 12 weeks interval. So do you follow any protocol? Let's say today you have given the injection.
Yes, sir.
You call him after 12 weeks or in between? You
No,
call?
sir, we are following them on a monthly basis maybe.
Monthly basis.
And if we know the pattern of recurrence, then maybe we can call them after 8 weeks or 12 weeks. Thank you.
The next talk is by Dr. Gagan Bhatia, Speed with Efficiency, New Generation Cutters.
So good afternoon, everyone. I'm sure by now all our Ang2 levels are upregulated. So let's talk about some surgical parts. So speed with efficiency, new generation cutters. In this, I think few slides have been given to me by Alcon. So where we started with this Machammer's MIVS design, which was a big cutter with fluidics also included in the cutter. And then from there, we moved to smaller gauge from 20 gauge to 23 to 25. I think we all would have seen these three, the transition from 20 to 25 gauge cutters. So vitrectomy probes basically evolved through the time, and one of the biggest evolution was the twin duty cycle cutter, which cuts in the pro and the con phase. So with this, I think with newer cutters coming in, I think even our wish list kind of improved, and we started desiring stable IOPs, which basically means controlled ingress and egress of the fluid, stable and efficient tissue response, so basically lesser pulsability, which basically means that when you go very close with the cutter, lesser movement of the tissue that happens. And also minimal traction, which is basically required, and very controlled vacuum, which was the desired list. So with the traditional cutters and with newer cutting, with thinner cutters coming in, I think the concerns were decreased vitreous flow, because obviously you have a lesser bore size, then increased surgical time, increased post-close time, and unwanted flexibility. We all remember that once the 27 gauge cutters had come in, initially they used to break. At least for me, they used to break a lot. So, but nowadays the newer generation cutters seem to have tackled all those problems. So as I said earlier, one of the biggest inventions in cutter technology was the twin blade cutter, or the TDC cutters. So this was something which Doc has initially stated that, so there is a cut which happens when the cutter probe moves in and out. So you're basically doubling the cutting rate. And if you see this video, you also see that seems to be very good flow that happens with the TDC cutter. So with this technology being introduced, there were studies that were done in literature, which I kind of went through, and they basically say that in this simulation model, with increased cut rate, with the TDC cutters, these had increased flowability with water, and as well as in egg white, which kind of simulated vitreous, there was better flowability or flow rate with a TDC or a dual cut mechanism. So probably the dual cut mechanism improves the duty cycle with the cutter port more open at more times. So that is when Alcon came up with Hyperwit. Hyperwit is the new 20,000 cut per rate cutter with a continuously open port, which has a dual pneumatic drive and a bevel tip design. So how this helps? So it's better, it gives better efficiency. So if you see here, the difference between this cutter and the TDC cutter is that the TDC cutter, sorry, so the TDC cutter basically has, so the TDC cutter basically, when it goes out it is active, but when it comes back it is passive. But in this cutter, the good thing is that the going in and out phase both is an active phase. Secondly, there is lesser traction because it kind of breaks the pieces into smaller fragments, and the bevel design basically helps us to go very, very close to the retina. So probably good to say that this has improved fluidic stability, which has improved efficiency, and also surgical versatility is there. Now to prove all these points, I went through the literature, and as David et Steele in the study basically said that as you increase the vacuum, the flow rate increases. That's pretty obvious. But then what is more important to see over here is that with the hyperwit, which is a 20,000 cut rate cutter, and the ultrawit, which is a 10,000 cut rate cutter, the 20,000 cutter has better flow rate when we just study it as a design for cut rate. So with increased cut rate, ideally you should have lesser flow rate, but with hyperwit you seem to have better flow rate, probably because of the dual cut design or a better duty cycle. Coming to tissue traction, again, the hyperwit, which is a 20,000 cutter, has lesser tissue traction in studies, and also if you go to this vacuum simulation model, so basically what I learned from this was that you need lesser vacuum to achieve the same flow rate with the hyperwit or the 20,000 cutter. So probably, many times when we have used the 20,000 cutter, if you go with the same vacuum setting, you do see a little bit of pulsatility. So which kind of decreases when you decrease the vacuum, because you achieve a good flow rate with lesser vacuum, making the surgery way more safer. So when we come to pulsatile motion again, the bevel design, how it helps is as you go very close to the retina, the surface of influence, so basically the amount of retina that it kind of catches is much lesser with the bevel design. So I think it would be safer to conclude that it is the newer cutter is more efficient, so because of increased flow rate, high cut rate, and better duty cycle, and with hyperwit being a dual active mechanism, maybe it probably gives almost 100% duty cycle to us. As far as safety is concerned, there is definitely reduced traction on the retina. It is smaller vitreous fragmentation, so basically because it's cutting very fast, so there are lesser, the fragment that you're pulling in is very small, and that is why the pulsatility is very less, and safer maneuverability is obviously there. So thank you.
Gagan, just one question. I've been using these 20K cutters since its launch in India. So my parameters are 400 suction for the core vitrectomy and 100 for the peripheral shaving part. Is there any difference in your settings or the same?
Yeah, mine would be for core.
For a RD case, not attached retina.
No. So in an attached retina, right? So
no,
in a detached retina, I think core would be around 250 to 300, and for shave mode, I keep it around 150. 150. Yeah, with the 20,000 cut rate. Initially, I was keeping it to same. I was keeping at 300 and 250. So the core was at 300 and the shave mode was at 250. But what I've kind of realized with these higher generation cutter is that because the duty cycle doesn't change during the modes, it's almost the same. So you probably with depending on the type of detachment and the the amount of fluid, probably I think a safer limit of roughly around 200 is okay with these 20,000 cut cutter.
Have you?
Please.
Have you experienced any change in reflux in between 10K and 20K cutters?
Yeah, definitely. So that is what I'm saying, that with the 20,000 cutter, really those 3 cycles don't really matter too much. I think the core and the shave is almost the same. Whereas in 10,000 you will find a big difference between the two.
I'm talking about the reflex action, what it gives with the cutter.
No.
It doesn't matter.
No, that doesn't matter.
With the 20K, is there any difference with the 10K?
With 20 gauge?
Yeah, with the 20K cutter.
No, I think it's pretty much the same. I don't think it's really different. What it probably is just made the shaving a little more safer. So the higher cut rate. Probably from 7,500 cut to 20,000 cut, there is a difference. So that ultra width, the 10,000 cut rate is, I don't think much of difference. But yeah, definitely the 751 and this, there is a difference there.
What about the proprioceptive feedback? Like in the sense that do you feel that from 10K to 20K there is more vibration or anything like that?
Slightly.
Is that an impediment sometimes, you know, when you're doing shaving of like diabetic membranes or something?
Sir, I just, again, I do feel that if you reduce the vacuum, that reduces a bit.
Okay, but it is a factor.
It is a factor. It is not that it is not a factor.
Because we saw that when we moved to 10K, you know, everyone noticed that, you know, there was more of a, you know, little bit of a vibration that you feel.
There. That slightly is there.
Yes.
Yeah.
So I haven't experienced.
Which I feel is that firstly they have discontinued the 23 with the 20K cutters. So you cannot do a 23 gauge surgery. So sometimes in difficult cases I would like to do a 23 gauge surgery, but now I have to do 100% cases of 25 gauge.
Oh, they don't have 23?
They don't have 23 gauge with 20K.
Yeah.
And the second thing is you cannot reuse it as many times as you could use a 10K cutter. So the life has gone a little bit. Yeah. So we all reuse, and that's a little, you know.
For some
and
reason,
the pack is a little more expensive than the 10K.
Yeah, and you have to buy packs of six. Yeah. But I think it goes true for all the instruments. The reusability has gone down for, I think, all the instruments.
Yeah, it has gone down.
In the past couple of years, I feel it has gone down. Yeah.
And even I think coming to Vishal's question, I think I don't think that, at least in my this thing, I would really define a 23 or 25 gauge based on the cut rate. I think if I have to do a 23 gauge, I'll go for a 23 gauge, whatever might be the cut rate. So I think that should not be impediment. But
then you see the practicality is that you have to buy 6 23K packs and 6 25K packs, and that is not feasible for every setup. That's what I'm trying to tell you.
So besides that, for vitreous hemorrhage, like it is a long-standing vitreous hemorrhage, have you used higher vacuums to 600 ever?
Yeah.
And do you say 23 gauge cutters are more stable than 25 gauge with that much of vacuum?
No, 23 gauge cutter will have a more followability, so you just increase your bottle height a little bit more than what it was, what you generally keep.
Take the bottle height.
But it's just, I mean, because nowadays most of the machine have active infusion. So if you're using active infusion, it kind of compensates most of the time. So I don't think it really matters. I think it's whatever works best in your hand and how, confident or how versatile you are with that, with your own machine. So I think vacuum is probably not this thing. So as Vishal also said, I think we all use almost the same amount of vacuum. But yeah, increasing the vacuum really doesn't matter if you're doing core per se. Thank you, sir.
Thank you.